Off this session, we have Cathleen McCabe, Light Scatter, True Caro.
I want to say that I have some experience with the one-step two, and it is really great. Sorry to point out your mathematical error, but what we learned is that Paul Singh's really good at treating the third eye. So anyway, I want to talk to you about tear osmolarity. I think many of us have already incorporated this into our pre-op assessment, but I think it is really key in how we work up our patients, because we often see patients like this, where we go in and we think, oh, you know, great. And I look at something like this and I'm like, this patient is going to be singing my praises. They're so happy. I can't wait to go in here and celebrate, dance with the patient, you know. But no. They're not happy, it's not as crisp, and I do get this question a lot. Hey doc, I think the lens moved. Like, well, did you fall? Did you hit your eye? Are you rubbing? What's going on? And it's just, no, they don't see quite as well, and they have fluctuating vision. And I think for dry eye, one of the most important symptoms that I ever ask a patient is there any time during the day, like any moment that you like your vision? Like if there's a moment that you like it, then the only thing that's changing throughout the day is the ocular surface. Everything else, your lens, your retina, your optic nerve, all those things stay the same the rest of the day. The ocular surface is the only thing that's changing throughout the day. So that's a very helpful question, and they do get that usually. So I really like the eye trace here too. It really is helpful because it shows this picture to a patient in a video. This is actually a video that what happens on the ocular surface as a patient is not blinking. So in between blinks, you see that this is a patient with dry eye, and that inferior part of the staining, which you see in the picture as well, is just getting worse as they keep their eye open. And so picture for me with patients is worth 1,000 words. They may talk about other things, you know, that are bothering them, like blurry or fluctuating vision or irritation. But if you show them this, they'll say, oh, okay, I see that there's something wrong there. Red is bad, and they get that. So how do we prevent those unhappy patients and, you know, try to just go in and have a happy dance with them? And really, I think in our practice, we really do concentrate on the pre-op part of the management of the patient to avoid many things, refractive miss, but also not diagnosing something that they had preoperatively, so that then we have to explain that we didn't create it during surgery. So dry eye is a huge one because most of our patients do present with dry eye as well. And it's not always that we see that. They don't always come in with symptoms, and they don't always come in with signs even. We're going to see that in a moment. So what is the prevalence? About 63% of patients have at least some hyperosmolarity when they come into the practice. And you can see this is a vital stain. The green is good. Those are live cells, and the dead cells are red. And this is obviously somebody with very dry eye with a 400 there. But 30% of those patients may not look very, very bad at the slit lamp. And you may not have a clue that that's going on. So if we look at what ASCRS committee came up with for their algorithm, we can see that, you know, we want patients out of their contact lenses, we want them not to be using drops, so we're not biased in what we're looking at, and it's not masking some of what we can see at the slit lamp. But part of that is not just their speed questionnaire, we use the dry eye questionnaire, but it's also tear osmolarity and maybe inflammatory too. And then depending on that, you can talk to the patient about whether or not they have dry eye disease. So what does it do? You know, why do we care about hyperosmolarity? Well, it makes a difference in our accuracy with our planning for patients. So you can see here that those patients who are hyperosmolar, those are the ones that have greater than a diopter of variability in their pre-op keratometry. And so we're going to see that we have more refractive misses in the patients who have untreated hyperosmolarity. And in our practice, we do take it really seriously. We do all this testing ahead of time, and we don't ever do the testing for their biometry on the day that they present, even though I know they're all referred in for cataract surgery. We wait and we treat whatever we need to treat in the ocular surface and have them come back. So how does that inform my decision making? Well, a patient who is very hyperosmolar, well, if they have a great eye, a happy eye, everything looks great, their OCT, their optic nerve, and their retina is perfect, they have reasonable expectations, of course, and their ocular surface and all the testing I can do looks great, including their osmolarity. They're a great diffractive optic candidate if they want a full range of vision. If something is off in any of those things, well, I'm going to see, is it something reversible or not? If it's hyperosmolarity and dry eye disease, maybe it is. Maybe we can do lots of treatments, but it's not just to get the good biometry and then one day post-op. Is it going to be maintainable for the expected life expectancy of the patient in order for them to still have good visual acuity? So those patients where I don't think that's going to be true, or we just can't get it as good as we would like, that's where a non-diffractive optic might come into play. And if it's really something they can't maintain and it's very hyperosmolar, maybe they shouldn't have any of those fancy optics, and we should just be trying to, take care of their cataract and maybe use a monofocal lens. So why is that? What does it do to quality of vision? Well, here you can see in patients with normal osmolarity, all of these light scatter indices are normal. That is not going to contribute partially to their quality of vision. But if they are hyperosmolar, and that's like 326, so if they're hyperosmolar, you'll see that there is this light scatter equivalent to having a grade 2 to 3 cataract. Well, we would be taking that cataract out to improve their quality of vision. So if we take their cataract out and they still have this, they still have that decreased quality of vision equal to what they would have had if we left their cataract alone. So they may not see the benefit of that improvement in quality. So here's what I mean about, sometimes you see hyperosmolarity, but normal signs and symptoms. So here's a study where you see tear breakup time in the two groups. Looks pretty good. I wouldn't be too worried about either of those. If you look at the staining, they really have no staining in either of the two groups. But if we look at hyperosmolarity, it's significantly different. And we know that correlates to satisfaction, 7 times greater dissatisfaction in the patients with hyperosmolarity. So we want to treat that, eliminate that, and have happy patients. So how do we do that efficiently? Well, TrueCare, we've been doing osmolarity testing for a long time. It was kind of a pain in the neck. We wanted our staff to do it, but they didn't like doing it. So a lot of the time that they would skip it. But it is so easy now, the ScoutPro, luckily. You can see that it's very accurate. So one of the concerns that we have is it's not reproducible, but you can see it's actually far more reproducible than cholesterol testing, glucose testing that we rely on. And it's not too bad to have it done. So here's the most positive technician you'll ever meet in the world. Happiest patient too, not so happy. But so easy, and we're going to see. Truly, I do have dry eye. When I say I have dry eye, it's because I truly do. But you get that test result really quickly. So quick and easy. This is not sped up in any way. That's exactly what it is. Really quick acquisition of the sample, even with a grumpy patient, and then really quick results saying, yeah, oh yeah, really do have dry eye. So thank you so much.
Thank you, Kathy. Let's give it up for all of our